Today it's very exciting. I get to interview one of my idols, Iron Man Josh Wren, pediatric dentist down in Mississippi. Josh and I share a passion for making dentistry faster, easier, higher quality, but also lower in cost so you can treat the masses. He's put some online courses on Dentaltown on pediatric dentistry. Amazing stuff. Josh, I'm so excited I get to spend the hour with you. Let's just start with the 4,000-pound elephant in the room. A lot of dentists out there, they would rather just go out there and chase a car and bite a bumper than treat a 2-year-old screaming kid with a toothache and do a pulpotomy. I always tell people that my 2 oldest sisters are Catholic nuns, and the reason I want to be a moral, ethical guy is because I fear that if I went to hell, I'd be in charge of the pedo clinic with Joseph Stalin and Idi Amin and Adolf Hitler for eternity. And so thank you so much for being one of the 9 recognized specialties in dentistry and pediatric dentistry. Josh, how do you do it? How do you work on kids with toothaches?
No problem, Howard.
And what made you pick that? Were you just a glutton for punishment? I know you are because you're an Iron Man. You know, what made you go into pediatric dentistry?
Just to be able to the enjoyment of alleviating dental fear from a child and let them have a lifelong healthy smile for the rest of their life without being terrified to go to the dentist. There's so many adults that were traumatized as children, perhaps not treated the right way, perhaps using a papoose board with not profound anesthesia or whatever the case may be. And I have a passion to get that child past that level into teenage and adulthood years, being able to go to the dentist and not being terrified every time they step into the dental office. You know, I hear a lot of adults still to this day say the smell of a dental office makes my teeth hurt, or the smell of a dental office makes me terrified, makes my blood pressure go up. That's what we're here for as pediatric dentists, to make that patient not alleviate those fears from that patient.
Well, that's fantastic. You mentioned right out of the gate papoose board. Is that still common in a pediatric practice, or has that been replaced with
I believe it is.
Pardon?
I believe it is. Maybe not from the usual group on Dentaltown. You know, we are the cream of the crop, as I say, on Dentaltown. We're the ones wanting to learn more about it and do things easier, faster, cheaper, as you say. But throughout the country, those that are not on Dentaltown, I would say it's very common for use of the papoose board. It's one thing to use it for patient safety, but it's another thing to use it for patient true restraint, restraining the patient. Under oral conscious sedation, it's still considered, I believe, the standard of care to use a papoose board. I haven't used one since residency. I don't believe in the use of a papoose board. If we're going to do any form of restraint, it's mom in the room restraining that child for a procedure, just due to the litigious society as well.
And that is true. You know, most dentists, when they go home at 5 o'clock, they're done, they're burned out, they want to watch ESPN and drink a beer. The dentists that go home and log on to Dentaltown for an hour or two, that is truly the cream of the crop. And you are the cream of the crop, leading the way on the message boards on pediatric dentistry. And thank you, Josh, for all that you do for not only dentistry and your own patients, but for Dentaltown. So what do you want to talk about today? What comes to your mind? What do general dentists need to know about pediatric dentistry?
Well, one thing I've seen a lot of, especially in the past few days on Dentaltown on the pediatric message boards, is negative reviews. So I think one of the big problems with social media and Google Plus and Google reviews and all of these things is the unknown of which parent is going to go home and vent on social media about the dental experience for their child. You know, whether it be through secondhand information or whether they were present and the facts got skewed or whatever. I think that's one of the bigger challenges we face in pediatric, not only pediatric dentistry, but all the specialties in general dentistry as well. I think that's one concern I have, and I know you've talked about it, handing a card when the patient leaves with specific instructions on giving you a review. If they leave the office happy, that's the time to strike. Maybe that could combat a few of the bad apples or negative reviews that are out there about you. But I think that's one problem. And I've seen it on the pediatric message boards. I think three threads about negative reviews. So I think, and first of all, thank you for allowing me to be a moderator on the pediatric message boards. I log in God, probably 100 times a day to check the boards, and there's a wealth of information on there. It's awesome.
The honor is all mine. So you talked about, yes, we do have a card. When you cement that upper single crown on a woman who was afraid that it wasn't going to match and look like some man wearing a bad wig for the rest of her life, and she's all verklempt and happy, and you just say, oh, do me a favor and do this, and you want them to do it outside of the office. Google's so smart. You don't want them doing that on your dental office Wi-Fi. Google's going to pick that up. You don't want them doing it from your dental office computer. You want them to do this, but most people don't know how to do it. I mean, I find in my office almost no one's ever wrote a review before, and a lot of times it's the first one. So yeah, we can manage to get a lot of good ones, and the bad ones we call them. We try to call them because they can take it down. And so what's your thoughts on managing online reviews?
Oh, we ask for specific reviews, and we use a company called Demand Force. There's been a great deal of information on Dental Town about Demand Force and Lighthouse 360 for patient reactivation or patient reminder system, but also Demand Force has a built-in review system to where the patient that is seen that day in your office gets review requests sent by email and text message. So we don't have if a patient leaves with a positive experience, they get a review. If a patient leaves maybe with information they didn't want to hear, they also get a review. So we don't pick and choose who gets the reviews. Everybody gets the reviews. If it's inaccurate information or if it's attacking information or defaming in any way, an office staff member or whatever, we can get that taken down. But we don't have to do that very often. We've done that twice in about 5 years.
And
we've had to take down negative.
And we know that women are probably 2/3 of the market for online reviews. They seem to value this more than men. So tell me, Josh, when you are a pediatric dentist, what percent of your new patients are you getting from pediatricians versus general dentists?
I get approximately 80 to 90 new patients a month. I would say 5% of those patients are referred from general dentists. And I would say approximately 15 to 20% are referred from pediatricians, and the rest are referred from existing patients, I would say.
Wow.
Or reviews, or parents reviewing the information online. We have a big online presence with Demand Force. If they Google Wren Pediatric Dentistry reviews, there's I think the number this morning was 147 reviews. So, and the vast majority of those are very positive.
I think that's very neat how your name's Josh Wren and you're wearing a red wren bird on your shirt. You're a natural born marketer. That's all good. So when dentists refer you a patient, what percent of dentists referring you a patient just blanket give you all the children versus just give you that one child that they couldn't work on because it went south?
Yeah, there's one particular practice that refers me every child under 12 that comes into their office. The rest are deemed behavior management patients, which could mean simple nitrous oxide and tell, show, do in the office. Tell, show, do is a big hit in our office. Tell, show, do works 90% of the time, along with the use of euphemisms. A drill is not a drill, it's a water whistle. You show them water squirting out of the whistle without a burr engaged, and hey, this is what we're going to clean your tooth with, is a water whistle. 90% of patients referred to our office for behavior management, and the number is 90%. I'm not inflating that number. Can be treated with 50% nitrous oxide and tell, show, do just fine, unless they have a mouthful of decay where it's going to be 4 appointments, and in those cases we use general anesthesia.
And do all 4 quadrants at once?
Correct.
Wow.
All 4 quadrants at once. An hour to an hour and a half.
So you really got to weigh out the dosage of the anesthetic. A small child, how many carpules of anesthetic does a child like that get? Are you used to 1 quadrant at a time to keep the breakdown of the anesthetic, or how do you manage that?
We do half mouth dentistry.
Half mouth.
So
right side, left side.
That's correct. And we use the isolite, which makes that a lot easier. No rubber dam. We use the isolite so we can work on the right side all at one time. Numb it up. If you have a 330, do everything you can with a 330 before you switch burrs. We have a spreadsheet where every single patient gets weighed before we do operative or restorative appointments. So any kind of treatment appointment, whether it's for bicuspid extractions, that patient gets weighed. We know exactly how much local anesthetic we can give.
And are you weighing them in kilograms or pounds?
We're weighing them in pounds and then just converting it to kilograms. The spreadsheet does that for you, and then it'll say you can give 2.2 compules of 4% septicane, or you can give 2.8 compules of 2% lidocaine.
Really? So, that's the only difference in septicane and lidocaine is 2.2, or were those just random numbers?
Those are random numbers,
but
okay. It's not that much. For 4% versus 2%, it's not true double.
Really?
You can give 7 milligrams per kilogram is the max dose on septicane, and 4.4 milligrams per kilogram is the max dose on lidocaine.
Wow. That is I've already learned something, and I read all your books.
And we use septicane almost exclusively, unless the patient's 30 pounds or less, maybe 35 pounds or less, we use septicane.
With epinephrine?
With 1 to 100,000 epinephrine. I've been considering switching to 1 to 200,000 epinephrine from some other people on Dental Town, so not sure what I'm going to do there.
So they sell a 1 to 200 on septicane?
Correct.
And a 1 to 100? Do they also sell a 1 to 50?
I'm not sure. I've used 1 to 100,000 for about 6 or 7 years now.
And by the way, if pediatric dentistry is an area you really want to massively improve, you can actually on Dental Town, you can follow Josh Wren so that whenever he posts, you get an email notification that there's more amazing information from Josh. That's a neat feature we have on Dental Town.
Thanks, Howard. And the app, if you don't have the app, download the app. My gosh, you can check on your phone anytime, whether you're in the airport or whatever, to pull up the Dental Town app. So download that. And one other thing, Howard, Wednesday, the new course is coming out, the new online CE course. It's pulp therapy, painless anesthesia, and stainless steel crowns for the pediatric patient.
And give them the title of all your online courses.
Excuse me?
And give them the title of your other online CE with Dental Town.
Simple space maintenance. As you know, Howard, we get tons and tons of questions. You follow the pediatric board, tons and tons of questions on, do I need a space maintainer here in this case, and what space maintainer do I need to use? That course is great for those kind of questions. It even teaches you how to fabricate your own space maintainers. We believe in low cost to keep our costs low, so I make all of my own lower lingual holding arches, wire nances, acrylic button nances, nances with Z-springs to kick out unilateral cross bites. I make all my own appliances here in our lab. So, but that course, Simple Space Maintenance, is great to answer those kind of questions.
Now, Josh, not to throw you under a bus, but are you really making all those, or did you teach your assistant how to make those for you?
I have one assistant that makes those, but I'm a little type A, and I tend to make all of my own space maintainers.
And how long does it take you to make a space maintainer?
For lower lingual holding arch, it takes me about 3 to 4 minutes.
Oh my God! Yeah, your online CE course where the dentist can actually see you make that is just an amazing. And then your new course is coming up this week
on Wednesday. Mm-hmm.
That's fantastic. So another question people are asking on the message boards. Sometimes you hear that a pulpotomy, if you use it with former creasel or something like that might be a carcinogen and you should use it with something else. Or talk about that. Are you worried that some agents in a pulpotomy could be a carcinogen?
I am. Despite all the stuff, a lot of studies have come out to where the level of formaldehyde in the bloodstream, even after a general anesthesia case, we're doing 8 pulpotomies with formal creasol. The post-op, the testing of the blood has shown no increase, no blood spike of the ingredients in formal creasol. But just due to all the negative publicity surrounding it and some of the questions we were actually getting asked by patients, I've chosen to stay away from formal creasol. I haven't used formal creasol since residency.
Wow.
I switched over to ferric sulfate. I use Viscostat by Ultradent. Been using that for about 6 or 7 years with good success.
Have you met Dan Fisher?
At first.
Have you met Dan Fisher?
I've never met Dan. I've heard a lot of great things about him.
Oh, Dan is just an amazing man. He's up there in South Bend, Utah, a suburb of Salt Lake City, and Since I'm 50, I'll be 52 next month. I'm old enough to where during his lectures he used to cut himself and put it on his cut, showing how it coagulates it so fast. I mean, there's a guy. So he made that. He invented that. I think that was his first product. He invented that in his apartment complex at his kitchen table. And
Wow.
so go through that technique. So you'll do a pulpotomy, then you'll just you put the brush. Dan, everything you buy from Dan Fisher Altgen's got a little brush applicator tip. Is that what you're squeezing out with?
Oh yeah, they all fit every syringe he's got. It's awesome.
In fact, one time I was
So
eating
yeah,
with
that's
Dan
exactly
at
what
the
I did.
wall. One time I was eating with Dan pancakes at the IHOP, and when it came to the maple syrup, he pulled out one of those syringes and just started brushing it on the pancake.
I believe it.
But
No, but the steps to that, I'll be honest with you, the first year or two, I had more failures, more internal resorption associated with it. On the message board, there's internal resorption scares all over the place with therapeutic pulpotomies for primary teeth. And I was having that trouble the first year or two until finally one of my colleagues, Neil Quinton, who's on Dentaltown as Q-Dog, he said, Josh, what you have to do is I had this trouble a couple of years ago. What you have to do is you have to go down into each canal, 2 to 3 millimeters, with a 2-round burr, get every bit of the pulp tissue tags that you can from that spot coronal, and then use your viscostat. Have no coagulum left behind. No coagulum. A lot of times people just get down to the pulp stumps, brush the viscostat on there. You're actually on top of vital tissue, and then you're getting your internal resorption. If you go down a little bit further where the pulp shrinks down and really constricts, at that point you don't have as much vital tissue, or that's my theory. Neil didn't tell me that, but that's my theory, that you don't have as much coagulum and medicament left behind. You do a good air-water rinse, put your temporary agent in there, whether it be IRM or Tempet, and then your stainless steel crown on top of that.
and are you doing that with number 2 round burr high speed or slow speed?
Slow speed.
Okay, slow speed. Okay, very good. And then
Slow speed.
viscostat, and then you put the viscostat, and then you rinse that off.
I do. I scrub the viscostat on there for about 15 seconds, and then we rinse it off with a thorough air-water rinsing, thorough air-water blast, and then put your temporary material in there, in the canal, in the chamber.
And what is that
And
usually for
then
you? Is that IRM?
I use Tempet.
Tempet?
It's just
Made,
easier.
made
It's
by who?
easier. I don't like mixing. Who is Tempet made by? I'm not even sure. But Tempet, and then we use usually stainless steel crown on top of that.
Now,
That's another debate, whether you can restore those with composite or you need full coverage, and I still use full coverage on this.
so have you tried direct adhesive composites, and what was your results with that?
Miserable failure.
Miserable failure. And what about the
Miserable.
chrome steel crowns that are tooth colored?
Oh, I love them. There's the new zirconias that are made by Easy Peto makes them, New Smile makes them, Kinder Crown makes them. They're great. I've
So
been using those for the mothers that value aesthetics. I use the zirconia crowns for.
and do you charge a higher fee for that?
We do. It's about I would say close to 50% higher.
50% higher? Okay.
Right.
And go on. And
So
are
I
you
just say, around $200 for a stainless steel crown, around $300 for a zirconia crown. Just for those out there wondering what we charge for this.
and do you have amalgam in your practice?
We do not. Hadn't used amalgam in about 5 years.
And what's your thoughts on that?
I love the bonding systems. I think if you have a properly isolated tooth with an isolite or a rubber dam, that the composites last as long as a pediatric primary tooth is needed for sure. But I believe heavily in them for 6-year molars too, with thorough isolation. I don't believe in cotton roll isolation or mirror isolations for a 7-year-old needing a resin on tooth number 19. But I think properly isolated, a resin can last a long time.
So Josh, back to that 6-year molar on a sealant. A lot of people, there's people on the message board that said if you don't go in there with a burr and do a preventative resin restoration, which is basically just an occlusal, that if you do a preventative resin restoration, you take a 330 and clean out all the fissures, then 5 years, 99% of them are still there. And if you just do a sealant and you acid etch pits and fissures filled with junk, and do a sealant that in 3 years they've all failed. Talk about that. How do you weigh in on that
And I would
comment?
say not in, yeah, and I would even add to that, not in 3 years those fail. If you etch and bond on top of organic material, then the grooves is going to fail within a few days. So I clean the grooves out either with abrasion or usually a fissurotomy burr, and etch and bond and seal.
So
I don't believe in not treating the grooves at all.
so then you do not believe in sealants.
I do believe in sealants, but I believe in sealants with a fissurotomy because I
But
will place sealant material.
isn't that an occlusal composite?
Uh, we had this debate with the insurance company around 4 years ago with one of the particular insurance companies, and they say no, it's not unless you're into dentin. Do not bill an occlusal composite. Still charge it out as a D1351, a sealant. Don't charge it out as a resin. So that's my terminology here. I guess it's from an insurance standpoint.
Well, that would probably legally be correct. But if you clean it out with a fissurotomy burr, aren't you always indenting?
No, no,
No.
you can be still in enamel, but you're right. It is a composite. At that point, in my opinion, it's truly a composite.
Well,
But
I would say this in my own eyes, and again, my eyes are 51 years old, and I have to wear magnification 3.5. But if when I take air abrasion and clean out the pits and fissures, it always blows it out to dentin. Is that just because the air abrasion is cleaning out too much or is strong enough to remove enamel, and that's why you're always in dentin? And if I used a fissurotomy burr, I could clean that out without being in dentin?
well, that's a good question. I'm not sure. I hadn't used air abrasion in quite a while, but that's a good question. I just lightly, as light as I can, go through the grooves, trying my best not to remove hardly any tooth structure, just to clean out the grooves. But
And
that's
how
a good
long
question.
and how long are you seeing your fissurotomy staying in enamel, cleaned out grooves, all in enamel, billing out as a sealant? How long is that gonna last on a 6-year molar?
I think that's going to last as long as it needs to, unless they're chewing on ice or something like that. I think they're holding up well.
But what is well? Is that 5 years, 10 years? I mean,
I
obviously it's
hope.
not gonna stay in there until they're 100.
Right. I hope. I've been at this in my own practice for 7 years, so I don't have the 10-year follow-ups yet, but hopefully they'll last a long time. And part of that is your bonding and your sealant material. You need a good one, something like ClinPro from 3M or something like that. I wouldn't go use the cheapest composite you can buy out of just any catalog.
Mm-hmm. Okay, and
And to add to that, I've been using a lot of flowable composite, Filtech flowable composite instead of a sealant material, just for the filler, for the additive filler.
for the sealant or for the preventative resin restoration with the
For
fissurotomy?
the Exactly, for the PRR,
Yeah, and
which I
and
still love that term.
and what
I
what
still love that term, but the insurance companies don't want to recognize it.
and Josh, you and I have had this conversation many a times. I remember sitting with you and just a few months ago for hours having this talk. But when we talk about pediatric dentists, there's 2 million dentists around the world, and a lot of dentists in Asia, Africa, Latin America. What are your thoughts on amalgam? I mean, should they be able to do low cost? I mean, can they get it done with bonding, or do you think? Do
I
you
think
think?
they can get it done. I think they can get it done with bonding if they have the materials. I mean, rubber dam and rubber dam clamp's not that expensive. But if they're not going to use rubber dam clamp, if they're just going to use cheap retraction with a mirror, I think the chrome steel crown's the way to go.
Okay.
You're talking about a low cost material that's going to last a long, long time, even on 6-year molars, badly broken down on 6-year molars.
Now, what do you think amalgam is not good for a child? I mean, do you feel it's unhealthy, or you just think it's a cosmetic issue and the mom prefers tooth colored?
Exactly. I don't believe it's a health scare at all. I would not hesitate to put it in my child's mouth, my 4-year-old girl's mouth if needed. I just don't see the point with good isolation. Now, without good isolation, amalgam all day long.
I left all mine are gold, but I did leave one amalgam in my mouth just so I could always tell mom, yeah, I don't do that, but I have one in my mouth, and there's no problem with it. I mean, it's funny, everybody that's concerned about mercury, how you get mercury in your bloodstream is eating seafood. And if you want,
Exactly.
and not from a dental amalgam, it's from eating shrimp and lobster and tuna. In fact, they're about this close in America to put a warning label on cans of tuna that you shouldn't eat it if you're pregnant. And I actually thought I was pregnant, and it turned out they did an ultrasound, and I'm retaining food. I'm not pregnant. And
Me
so,
and you
so
both have that problem.
no, you look ripped when I saw you last. You just did another Ironman or a half Iron. You did the Ironman in Florida, and then you just did a half a while back.
That's correct. I did a half in Knoxville, which was extremely hilly, and I have another full coming up at the end of September in Chattanooga.
And my dream is this year, the Arizona, I only do one Ironman a year. I do it in Arizona. This year, 7 dentists, 7 townies are doing it. And and you said you're going to do it next year with us, 2015?
That's my goal.
Can I hold you to that?
You can.
All right, you can stay at my house. I'm only 10 miles from the entrance still. But so what else you want to talk about, general dentists on pediatric dentistry? Where do you want to go next with this?
You know, well, wherever you want to go with it. One thing is in my opinion, pediatric dentistry is easier than general dentistry. I mean, it really is. As far as it's behavior management. It's knowing how to talk to the kid, being comfortable with the kid. It's not having mom back during the appointment makes things 20 times easier.
But you said, but you said you bring mom back there for the restraint, and now you said you don't want mom back there. So talk about that.
If any restraint is needed, mom is in the room. For example, if it's a 2-year-old that fractured tooth number F into the pulp, and we're not going to do a pulpectomy and a cosmetic crown, mom wants the tooth pulled, mom is back there restraining the child.
And is mom sitting in the chair holding her, or is mom facing the child holding her down?
More times than not, mom is sitting in the chair with child on top of her chest.
Okay.
Which is a nightmare. I mean, to be honest with you, that's the least favorite part of my job. Because I know mom is in tears because her baby's hurting and is having to have a tooth pulled, and I can't stand it. I probably despise doing that more than anything in dentistry.
And it's tough. I mean, I only had one accident with one of my 4 boys. He fell off a bike, and I started crying before he did. I think he only started crying because I started.
That's right.
It's a hardwired thing with mom and dad. Let's switch to
Go ahead.
No, you go ahead.
But I just think that's the biggest barrier to general dentists not treating kids. A lot of times is I'm not sure if it's a comfort thing. I'm not sure if the right protocols are not in place. I'm not sure if mom is back there interfering with the communication between the dentist and the child. But I've just seen a lot of reports on that, and it does make your job a lot easier to have that one communication with the child without mom interfering, using your own phrasing. Not the child can leave the appointment and never feel a thing and trust you for the rest of their life if mom's not in the room.
Yeah, and I can't believe
they trust the daycares with their children. They drop their child off at the daycare and send them off into the teacher and trust that teacher is going to do the right thing, teach their child well, and a lot of times we're just asking for that same trust, you know.
Yeah, I remember dropping off my oldest boy first time at not kindergarten, preschool. And it was the first day, and I went to drop him off, and Eric was crying. He was hanging on to me, and all that kind of stuff. And I said, he's upset. And a little 16-year-old girl said, well, if you just leave, he'd be fine. And I'm sitting there thinking, yeah, I'm a dentist. I should know that. So I put him down, and I ran out. But then I went to the window, and I peeked in the window, and sure enough, the instant I was gone, Eric was running off playing with 3 other guys. And so those kids have a trained response. They always know if they cry, mom's going to come running. So once they don't see mom, they realize that strategy isn't going to work with a complete new person like Josh Wren. So Josh, I want to talk about, I want to change subjects completely. When we think about dentistry for kids, you can't think of dentistry for kids without bringing up, Medicaid, Medicare, things like that. Do you participate in any Medicaid, Medicare? Are there fees enough for you to get involved with that, or is that just not working?
They're not. Well, their fees are okay. It can work with high volume dentistry, which is high stress dentistry. A lot of hospital work. You're seeing a lot of 2 and 3 year olds for full mouth dental rehabs, and it just didn't work for me. I did it for 3 years until September 2010, and then I chose to opt out of Medicaid just to change my practice style to more orthodontics and some PPO and fee-for-service dentistry instead of the Medicaid. And one of the things that caused me to do that was the guy I mentioned earlier, Neil Quinton, just going through a Medicaid audit, and them getting back with him saying, you owe X amount of money. We deemed 40% of your crowns unnecessary that you did in hospital dentistry, without having any proof whatsoever. And they had non-qualified people reviewing the documents. They had general dentists, not pediatric dentists, and not only not pediatric dentists, they weren't board certified pediatric dentists. They weren't capable of interpreting the information given. Told him he owed X amount of money. Well, 8 of my colleagues went through the same thing at the same point in time. And then I started reading more and more on Dentaltown about some of these scares, and that's the main reason I chose just to get out of it. I was doing everything as ethically and morally and documenting everything by the book, but I still worried about it. And I thought that was a part of my practice I didn't need at that point.
Well, if we learned anything throughout human history, is that if you get in bed with the government, you're going to get screwed.
That's exactly right.
Yeah, and that's sad, but so true. So what else you want to talk about? We're at the halftime now. We're 30 minutes in. We got 29 minutes to go. What else? Where else you want to take these general dentists in the world of? And my series is uncomplicating dentistry. How can they uncomplicate pediatric dentistry?
Let's talk about let's go along with the same lines about the government-run insurance, and let's talk about private commercial insurance and the struggles we're dealing with there. The premiums are going up, and the reimbursement rates are staying the same. That prevents a major problem for a lot of people. One of our problems is whether to become in network with certain insurances, just like general dentists are. We're I would say 10 years ago as pediatric dentists, we did not have to sign up to be in network with some of these companies, with the Delta Dentals, with Blue Cross Blue Shield. And now we're starting to see that we have to, whether it be from corporations starting to establish general dentistry for kids, or some of the small smiles and cool smiles opening up, and they're in network with every insurance company. And some of the general dentists are quite frankly out there starving, and the pediatric patients that they used to send us, they're no longer sending us anymore. They're wanting to treat themselves in their office. So, those things may lead pediatric dentists to join more networks, to join more insurance companies. So that's a struggle I think some of us are dealing with. And as we've talked about in the past, new dental schools opening up every day, new residencies opening up every day, the mid-level provider scare, more people being treated by mid-level providers in certain states. That may work its way down throughout the rest of the country like it is in Minnesota. What are your thoughts on the mid-level provider, Howard?
Well, I think it's right now in 2014. It kind of reminds me when the hygienists went to independent practice. It was a big uproar, and only like 5 hygienists in the United States did it. It was in Colorado, and the mid-level providers. It's in the early MC. We haven't seen the impact from it yet. But what percent of your patients have insurance? I mean, what percent don't even have insurance? I mean, we keep seeing national numbers that half of America, there's 330 million people, that half of Americans don't have any form of insurance. So is your practice half of them don't even have insurance? Or are you seeing it's the half with insurance that are coming in to the dentist? And if they don't have that,
that's what I think it is. I think it's the half with insurance that are coming in. Our practice is about 12 to 14% no insurance, and the rest are insured.
So that's a big sample size showing that if a person has a subsidy, a form of insurance of someone else paying for it, that they're far more likely to go see dentistry.
I agree. And
Yeah.
we offer incentives for those without insurance to, we offer 20% discounts from the hours of 10 to 12 for those without insurance. And we advertise that just as a way to get those patients to get them a dental home as well.
And another big controversial thing, I get attacked by this all the time in my backyard. I was involved with getting Phoenix fluoridated back in 1989, and then again last year. And I've had a lot of people upset with me for that. What do you think about community water fluoridation? And do you think it's a health risk? Do you think it's a benefit? What are your thoughts as a pediatric dentist?
I think it's a big benefit. I don't want to pigeonhole anybody, but the ones that come in, the parents that come in that say they're against fluoride, well, those are the children that do have active decay and a lot of rampant decay. But I think water fluoridation is the best thing to happen to dentistry maybe ever. I really do. I think it's preventing caries like crazy. I don't know the percentage, but and topical fluoride and the use of fluoride varnish. I think those are big. We have a seesaw where there's so much sugar in the diet, sugar, and the fluoride has to balance that out somewhere, and hygiene and coming to the dentist and that sort of thing. If not, you're going to deal with a lot of active decay. I'm not scared whatsoever about detriments to the body that fluoride is causing. Really not.
Let's talk about fluoride treatments to your office. Are you using a fluoride varnish? Are you using fluoride trays? Are you doing a fluoride rinse? And how often does a child need that? Is there some people say that it's only effective if it's done every 3 months. Some people say it's effective done every 6 months. Talk about that.
Yeah, that's another insurance thing that we're having to deal with. Some companies, most companies now, have gone to a once a year fluoride treatment. Well, in my opinion, there's no benefit to a once a year in office fluoride varnish, and we use fluoride varnish exclusively.
And say what do you mean by fluoride varnish? So it's a sticky varnish application as opposed to the foam in the tray or the rinse. Why do you go do a fluoride varnish and not the spray foam in a tray or a rinse where they swish for 60
The fluoride
seconds?
varnish it adheres to the teeth a lot better, and the effects of the fluoride varnish last for about 6 to 8 hours, even if the patient eats or drinks after the fluoride varnish.
And what brand are you using?
I'm using 3M Vanish.
3M Vanish. And
3M Vanish.
you just take and tell them how you apply that and how long that
Okay,
takes.
it comes with a little brush, and after you remove any plaque on the teeth with your regular prophy, you get the teeth dry just with a cotton roll or cotton gauze, and then you just you dip the little brush into the fluoride varnish. It comes, I think it's 0.2 milliliters in a little dispenser, and you just apply it on the buccal surface of all the teeth, and we then do the lingual surface, palatal surface of the teeth, and then we actually floss the varnish down in between the teeth after that.
And
very quick,
and
quick and easy. It's not readily evident that it's on there, but you do need to tell the parent when the patient leaves, because they say, "Oh, let me see your teeth," and then there's sticky junk all over their teeth, and parents think it's plaque or something. So you need to tell them that's what the sticky stuff is that's on their teeth.
And what code do you bill that out separately, or is that part of the cleaning fee?
We do. We bill it out separately. It's D1208.
D1208, and what's
there's
the
a D1206. There's a D1206, and there's a D1208.
And what's the difference between the two?
I believe the old 1203 has become the 1208, which is any topical fluoride, and they form the D1206 as the fluoride varnish code.
Okay. And and obviously that works a lot better if you're getting it twice a year than if you get it once a year.
Oh, it does, and we still recommend it every 3 months for high cavity risk children.
And so, are you still seeing baby bottle tooth decay, or is that are the patients educated enough where you see that fading away, or is that still an issue?
That's once or twice a month in my practice in Mississippi. We still see baby bottle tooth decay.
And what
it usually It usually is in the lower socioeconomic status. It's the ones that think 100% fruit juice is okay that it's not real juice.
Right. Yeah.
So we still do see that.
Yeah. That's sad. That's been going around for a long time. I also know that you're very focused on your staff. You don't you take staff management as serious as anyone. Talk about that for a while.
I do. Staff loyalty is big in our practice, and the way I treat them is big in our practice. I do not like staff turnover at all. Just as you've spoken and recently put on social media, all the wonderful years your staff has put in with you, I strive to do that same thing. Just treat the staff good. Have fun at work. Don't let it be a stressful environment. My God, we dance around and sing and watch Madagascar and have rhyming games with the staff while the patient's in the room and the patient joins in on it. We have a fun environment here, and I think that's what it takes to keep staff happy. It's not necessarily always about the money or the benefits. A lot of times it's about whether they dread coming into work or whether they're happy to come into work, quite honestly. And that's what I hear from my staff. My new office manager, Howard, is 21 years old. I have a 21-year-old office manager that's the sharpest employee I've ever had. And she was out on maternity leave for 4 weeks. She said she was ready to come back to work. She was going to originally take 8 weeks off. She came back after 4. She said, I'm ready to come up there and have some fun, be around you guys. And I think that's what it's all about. That person, in my opinion, will be here forever. As long as I keep treating her right, she keeps having fun at work.
Yeah, and that's helps so much with relationships with your patients. I mean, they bring you their child when they're 2 or 3, and they're going to be there till they're 18 years old. It's nice to always come in and see the same dentist, same receptionist, same assistant. I got to tell you, so let's talk about that. When does a child need to see the dentist? Sometimes you hear not until the first tooth appears. Sometimes you hear on the first birthdays, the second birthday. What's your thoughts on that?
Well, we're active in the OBGYN's classes in the community. So we start getting the education out there before the patient's born. Whether it's cleaning the mouth out with xylitol wipes before their teeth in the mouth, and then to present to the dentist no later than 6 months after the first tooth comes in. Instead of saying a set age, 1 year old, which is a good number, and it was a good advertising or educational campaign for the AAPD to put out. But some children don't have teeth yet at 1 year old, and some need intervention before 1 year old. If the tooth comes in at 2 months old, we want to see them at 6 to 8 months old. So the cavities can form very, very quickly. So that's my general rule: is 6 months after the first tooth erupts. But start health care at home before you ever even come to the dentist. And we try to get all the information out there to the pediatricians. Pediatricians usually, on average, sees the kid 6 to 10 times before the dentist ever sees the child. So if we can get the material out there to the pediatrician to give to the patient, that's fine with us. We don't necessarily care about the patient coming into the office when they're born or at their 2-week check or whatever, but we want that information disseminated to parents out there where they can start the good at-home care.
And Josh, are you seeing the first tooth appear faster and earlier in girls than boys?
No doubt about it.
No doubt about it.
No doubt about it. I saw about 2 weeks ago, I saw a 3-year, 11-month-old African-American female that had already lost O&P and E and F and had already been replaced by 8, 9, and 24 and 25. I had seen that. I've seen 9-year-old boys, white males, that have not lost a tooth.
Right.
So there's definitely a gender and a race predilection for when teeth come in.
Absolutely. I've noticed that big time. And which tooth are you seeing come in? What should they expect to be seeing? Which tooth coming in first? What is your general eruption pattern of what you're seeing come in first?
Yeah, it's E and F and O and P. Which one comes in first is kind of debatable, but most people will say that you'll see those bottom front two teeth O and P come in first, and then you'll see E and F, and then you'll see D and G come in beside there.
And do you also see, seems to be that babies look a little more class 3 when they're little, and then they grow out of that. I mean, overbite. Their mandible seems to be growing small. It seems like a lot of concerned parents coming in like, my son's gonna have a weak chin, and then they kind of grow out it. Do you see that mandible growing slower than the maxilla?
Yeah, we do. We definitely do. It's slow. The growth rate, it starts later but grows longer. So I'm not worried about the class 2 at such a young early age, and they're saying it's an adaptation thing. It's for suckling is what it is. I mean, the lower jaw is set further back. That's what they're hypothesizing in the growth and development world, that it's a suckling thing to keep to let them suckle better.
And also, we were talking a couple months ago about current trends in pediatric dentistry, indirect pulp therapy versus prophylactic pulpotomies.
Yeah, when I was trained in residency at the University of Kentucky, a lot of the professors still taught to us prophylactic pulpotomies, or one professor in particular. I don't want to call out the whole program because the whole program didn't do that. But anytime you're close to the pulp on a primary tooth, do the pulpotomy and then cover it with a stainless steel crown. That has turned 180. Now, even if there's still decay present, if you're close to the pulp, clean the DEJ around circumferentially as good as you can, get it as clean as it can be. Any decay remaining on top of the tooth, you leave behind. You put a glass ionomer on top of the tooth, and then you restore. Long-term studies are showing that has a success rate 95 to 98%, whereas the standard pulpotomy, even followed by stainless steel crown, has a success rate to 88 to 92%. So we're starting to see really long-term studies showing that indirect pulp therapy is the way to go in the absence of symptoms.
And also, what about we're talking about a solo practice model, being the solo practice model being a thing. What are your thoughts on solo versus? I
think it's going to become a thing of the past, and I know that's been an active topic on Dental Town. And the pediatric message boards, we're a little further behind the system, I believe. There's very few group practices that are pediatric practices. Most of us are all individual practices. Well, I believe with the number of pediatric dentists coming out, that the solo practice will probably be a thing of the past. I think if you can find somebody that's compatible with your treatment philosophies and your personalities, that the group practices in 20 to 30 years will greatly outnumber the solo practices.
And do you say that because then you could have extended hours? I mean, like, what are your hours now, and how much do you have to be available evenings and weekends?
Definitely. I'm available 24/7 unless I have the other pediatric dentist office in my town cover and call for me. Have my cell phone number on our voicemail. I still work boutique hours, if you will. I work 8:30 to 5, have an hour for lunch, 12 to 1. But I think that is a definite benefit to having a group practice.
Are you open on Saturdays?
I'm not.
Yeah. And if
I'm very seldomly open on Fridays.
So you're mostly Monday through Thursday.
Right.
And
I don't think we're going to have a choice in a few years. I really don't. I think we're going to have to extend hours. We're going to have to. I don't see things getting better without extending hours. I don't think we can raise our fees and decrease our hours or anything like that. I don't think we can work less and make more, like I thought we were going to be able to 5 years ago.
And how often are you getting calls on the evenings and and Friday, Saturday, Sunday?
Very rare. Very rare. Every new patient that leaves, I handle my business card and write my cell phone number on the back of it and hand it to them and say, call me if you have any questions. And I started that when I opened up my practice, and I would say I get maybe 2 calls a month, something like that. And more times than not, it's a general question that can easily be answered, and I don't have to come into the office.
Yeah, I have always found it strange that so many dentists are unlisted, don't give out their home number, blah blah blah. And to me, I think at least in Phoenix, Arizona, people are very respectful of a dentist time. I give everybody my business card. It's got my email, my cell phone number, and it's not abused at all. I had one funny one the other day. All of a sudden, my phone started ringing in my pocket, and it was the lady in the chair She didn't believe that was my real cell phone number, so she was gonna catch me right there. And my phone starts ringing. I look at him and go, "Oh, that's a local call." And then I answered, and she goes, "Oh, is that really is your cell phone number?" I thought that was hysterical.
Yeah.
So we're down to 10 minutes, Zach, Josh Wren. How do you? I just called you my son's name, Zach. Josh, 10 minutes. Wrap this thing up. What else can a dentist do to uncomplicate pediatric dentistry?
Other than following the message boards on Dental Town, go find a local pediatric dentist, and on your day off or take a day off, go watch them work. Go watch their office work. If it's a pediatric dentist with a good reputation, go watch them work, see how they communicate with the kids, see their verbiage, see their terminology. That's going to improve your skills with pediatric patient more than anything, in my opinion. I welcome general dentists to come to my office to watch whenever they want. If they're confused on certain procedures, I'll call them and say, I have pulpotomy or pulpectomy coming in tomorrow morning. Do you have a chance to swing by or something like that? If they're confused on a procedure, how it should work, how to treat the patient, how to give anesthesia, that sort of thing.
And that also speaks volumes about you, and it's also only the street smart dentist does that. I think the book smart dentist, they always got to fly to another city and drop $5,000 and close their office and make a mountain out of a molehill. And I've seen that too. I'm street smart, and I've for 25 years, there's just so many dentists. I mean, I remember back in my early career, an endodontist, Brad Gettleman, he had an open door policy. I think most dentists would fear that an endodontist wouldn't want to show you how they do endo because then you wouldn't refer to them, and that's just completely the opposite is true. Here you're a pediatric dentist, and I think a lot of general dentists in your state would think, oh, well, he'll never show me because he wants me to refer to him. And here you're exactly the opposite, open door policy. You love people, you love to share, and that with 7 billion people on earth, someone other than Josh Wren has got to do a pulpotomy too. And,
exactly. And it's all about the patient. I mean, do whatever's best and easier for the patient. That's what it's all about. And of course, we got to keep our doors open, but if it can make the experience better for a pediatric patient in another office, I could care less who does the procedure as long as they do it right.
Now, if a child walks in your office versus a general dentist office, does that office look more pediatric orientated? I mean, talk about that. I mean, do you have, does your office waiting room more geared towards children, and how much of an effect does that have?
It is. That's who it's geared toward. It's geared to the children, but our front desk knows to cater to the parent. The office aesthetics is geared toward children, but we cater to the parent, if that makes any sense. So when they walk in, they have toys to play with, books to read. Mom has magazines to read, is offered coffee or bottled water. But you can tell when you walk in the door, pictures of giraffes painted on the wall, or games to play with, that sort of thing. It's all fun and games when they walk in the door. Nothing serious when they come in the door. Everything's fun, and we're very interactive with the patients, and we're silly. It oftentimes reminds me of Patch Adams. I'm not sure if you're familiar with that movie.
Sure, absolutely. Robin Williams.
Yeah, exactly. That really molded me early on. I walk around acting just as goofy as he did. The kids leave here thinking, where was the dentist? I didn't see the dentist today. Well, there's that goofy guy walking around with dancing and singing. But that, in my opinion, they know they were at a pediatric place. So it's all about the experience for the children.
So do you wear scrubs, or do you wear a dress suit, or what do you wear?
No, scrubs.
You wear scrubs?
The same monogram you see here with the bird and the Wren Pediatric Dentistry on the arm. No white coat. Loops during procedures, not for hygiene. It's very unintimidating attire, and of course it helps only being about 5'6". I'm not 6'6", so.
And if Josh Wren sees 100 patients, you said earlier 50%. Oh no, you said 100 patients referred to you for behavioral problems. 50% you can manage on nitrous. But let's take your whole practice. What percent of your children get nitrous? What percent have to be taken to a hospital or hospital dentistry? And if you do a hospital dentistry, do you do the IV, or do you have a anesthesiologist do that?
I work with an anesthesiologist that does the IV and the intubation. We did an anesthesia rotation in residency, so we started our fair share of intubated quite a few patients. But we work with an anesthesiologist. They do all of that. We do the dentistry. I would say, to answer the question about what percentage, I would say around 3 to 5%. That's not a set number. I'm not sure. That's not an exact number. Have to undergo general anesthesia. I would say, other than that, children that need treatment, restorative treatment or extractions, 95 to 99% get nitrous oxide. I just think it makes the appointment more pleasurable. Helps calm them down, even if they don't appear nervous. And it's 50% nitrous every time. It's nitrous nose goes on, 50% nitrous from the start. No waiting the numbers, and I've had 2 patients vomit in 7 years. I mean, it almost doesn't happen. That's the biggest side effect. So it just makes the appointment go by.
What I am most proud of is the very few times that I've had a pediatric patient vomit, I was fast enough to push the jaw over, and it all went on Jan. And I have proud to say I've never got a drop on me. I'm very proud of that. So you're saying basically if they're going to get a shot and a pulpotomy or an extraction, they're going to be on nitrous at 50% nitrous and 50% oxygen.
They are, and they're going to be watching their favorite movie that's playing on the TV every single time. And
1 out of 20, 3 to 5% are going to have to go to a hospital setting with a board-certified anesthesiologist, and they're going to intubate them.
I would say less percent than that, but that would be the approximate percentage of patients that were referred to me that would need general anesthesia. I would say is around 5%.
And what are they intubating them with?
So that's about right, Howard.
And what would the anesthesia be if they're being intubated, for clarity?
Anesthesia would be succinyl choline to intubate, and then they would use narcotic and maybe propofol.
Okay, so you're down to 3 minutes. Wrap it all up for 3 minutes. If someone is only going to hear Josh Wren for 3 minutes, uncomplicate dentistry and wrap up our hour.
Go check out and talk to your local pediatric dentist. Take a look, watch them do what they do. Get on Dental Town, search around, watch some CE on there. Again, we've got another one. You would probably learn pediatric dentistry from an hour course on Dental Town than you could by searching all the message boards. But search if it's a question that's been asked on Dental Town on the pediatric message boards. So go see your pediatric dentist. Feel comfortable with it. You're gonna have to see pediatric patients in the upcoming years. So make it pleasurable for yourself.
Well, Iron Man Josh Wren, it has been an extreme honor to interview you today for an hour. I'm sure all the readers loved it. If someone wanted to just email you a direct question, can they do that? And
absolutely. It's jxwren, WREN, 78 at gmail.com. Email anytime.
And what's that 78 come from?
Look us up, wrenpediatricdentistry.com, and we're also on Facebook. Excuse me, Howard?
And what's the 78 come from? Is that the year you're born?
It is.
Okay, I thought so. That was a slap in my face since mine's 62. But hey, Josh, thanks for a great hour, and I can't wait to see you on the message boards.
Thanks, Howard. You rock.
All right, buddy. Bye-bye.